So I am joined this morning by consultant cardiologist, Dr. Boon Lim, and consultant geriatrist, Melanie Dani. And I am delighted to have you both with us today because my wonderful Facebook group have a lot of questions for you both, as you might imagine. And we're going to work through those slowly over the next hour. But what it would be really great for you to both do individually, and we'll start with you, Boon, if that's all right. If you can just tell us a little bit about what you're doing right now and your interest in COVID and why it is that you are someone that we should be talking to.
Good morning, Susie. It's a pleasure to be here, and thank you so much for the invitation to be with you at the Zoom consult and for inviting Mel. So I'm a consultant cardiologist. I'm based at Imperial College Healthcare NHS Trust at Hammersmith Hospital in London, and I've run the Imperial Syncope Diagnostic Unit for over 10 years now. And in the group of patients that we see and we tilt, and the tilt table test is one of those tests that we use to define and quantify autonomic dysfunction. We've now seen a large cohort of patients with long COVID coming through. And so from this experience, Mel and I wrote a paper on autonomic dysfunction in long COVID. And I believe it's one of the earliest, if not the earliest paper published on the 1st of January of this year, which will give you the link of the paper at the end. It's a very short communication, easy to read, and for your members, some practical advice as to how to mitigate symptoms. So that is me. I'm a cardiologist with an experience in long COVID as I ran the Imperial Syncope unit. Thank you.
Fantastic. Thanks, Boon. Sorry. Melanie, why don't you tell us a little bit about yourself?
And thank you also. I also want to say thank you, Susie, for inviting us to this webinar. It's great to be here. So I'm a consultant geriatrician at the same hospital as Boon, Hammersmith Hospital in London. I'm also a general adult physician. So I have had a lot of experience over the last year in managing COVID patients in hospital and have seen the different waves and different surges of problems right from the day of infection up until when patients are coming back month after month with more symptoms of long COVID. So that's kind of where some of my experiences come from. And then I also work with Boon in the Syncope and Autonomic Clinic at Hammersmith Hospital. So seeing the patients returning with long COVID. So that's where my interest is.
Fantastic. You're an amazingly dynamic duo, I think, and you're exactly the kind of people that we need access to. I think one of the things that we've, in our Facebook group, we've been really aware of is that people are waiting a really long time to get access to information. And that takes its toll on people's ability to recover because, you know, once you're putting on a waiting list, there's a sort of a pause that's pressed on your ability to recover. And it's such a gift to be able to reach out to you with, you know, we have an amazing list of questions here that have been compiled by the people in the group. Because actually, if we can get some information to people now, they might be better by the time, or feeling a lot better by the time that appointment comes around. So, you know, the power of information, I think, and if we can shed some light for people today, that would be an absolute gift. So we're going to jump right in, if that's okay. I'm just going to read here a little bit. So lots of people are getting clear or normal test results back from things like ECGs, CT scans, X-rays. A lot of people are beginning to understand more about things like POTS and wondering, oh, do I need to see a specialist? Do I need to get my doctor to refer me to a cardiologist? But maybe if we could just talk a little bit about POTS to start with. If you were going to diagnose someone with POTS, so it's postural orthostatic tachycardia syndrome, if you're not quite sure what POTS is, obviously you two are experts in it. What would the markers be? What should we look out? What should we be looking for without a tilt table test? So before they even get to you, should they be, you know, doing certain things? And what would help them understand that that might be appropriate for them? Boon, can we come to you first on this one? If you unmute yourself, Boon, that's going to...
Sure. So POTS, as you say, is postural orthostatic tachycardia syndrome. And it's a syndrome of autonomic dysfunction, particularly in relation to the cardiovascular system. Because if I read those words one at a time and I explain what those words mean, then you might understand the syndrome a bit better. Postural and orthostatic pretty much mean very similar things. Postural means a postural change. Orthostasis means standing up. Tachycardia means a heart rate of greater than 100 beats per minute. And a syndrome is a collection of things or symptoms that define a condition or illness process. So if you distill that phrase, POTS, it simply is a description that when a patient stands up and has to fight gravity, they get tachycardic or their heart rate races. And there are particular qualifications of that syndrome that mean that your heart rate has to rise by greater than 30 beats a minute when you stand up and be maintained at that level of increase for more than 10 minutes after standing up. And you also have to develop symptoms related to POTS when you stand up. It's either that or your heart rate goes greater than 120 beats per minute. So essentially, it's a descriptor of what happens to your heart rate. But please, and I want all of your the people listening in to really get this. If you stand up and your heart rate goes up by more than 30 beats a minute, but you don't have any symptoms of POTS, and we'll come on to symptoms in a short while, you shouldn't consider yourself as having POTS. So it's a very specific combination of this change in heart rate when you stand, together with development of symptoms that defines POTS. So that's the strict definition of POTS. Mel, do you want to talk about some of the symptoms of POTS that patient might experience when they stand up?
Yeah, so a lot of these symptoms relate to the reaction of the body and some of the dysfunction of the body when you stand up. So difficulties that people may report are dizziness, extreme fatigue on standing up, but most commonly that sense of palpitations. That's the sense of your own heart beating, and your own heart beating very fast and not stopping. Pains in your chest, again, which is related to your heart beating very fast, and breathlessness. So a lot of people would say, you know, you're okay when you're sitting, and then you get up to go and do some housework, and these symptoms get so severe that you actually have to stop midway, or people might be walking down the road and actually the symptoms overcome them and they have to stop. Other symptoms, so the sort of core ones would be dizziness, pains in the chest, breathlessness, the sense of the heart racing. But then you get a wider set of symptoms related to all the hard work that the heart is doing. And that includes disabling profound fatigue, the sense of brain fog, which I think probably your listeners are aware of, which is just your brain not really being able to function as it used to, the sense of a sort of veil over the brain, so you're not being able to work as normal. And then some other symptoms related to different organ systems. So, for example, some people might find that their periods change. Some people might find that their bowels change. A lot of people report diarrhea, abdominal pains, abdominal cramps, problems with their waterworks. So it's quite a varied constellation of symptoms. And I think we would probably come along to that in a bit more detail.
It's interesting that you mention the change in periods and bowel, because I think they're really significant symptoms that many people have across the group. But I think what you've just said there is, you know, those other symptoms that you've been talking about have to be present for it to be POTS, because I think, you know, there'll be quite a lot of people who have tachycardia on standing, but it won't be accompanied necessarily by that kind of deep fatigue, that dizziness, that need to just get back down into a recumbent position again to sort of protect yourself.
The other thing to mention is that we've seen quite a few patients who would fulfill the criteria of POTS following COVID. But we also know that actually it is a range. So autonomic dysfunction and autonomic disorders follow a range of different presentations. And so probably more patients are presenting with these symptoms, but with the criteria that don't fulfill the criteria for POTS, but maybe what we call a sub-POTS type. We don't know enough about it yet. There's not been enough published, not enough data published, but it's thought that the majority of people will have this orthostatic intolerance or difficulty standing up, but may or may not fulfill the criteria for these syndromes. And what we don't know is whether or not they're going to behave like a POTS patient physiologically, or whether it's going to take a milder or more severe course. And that's the subject of research studies at the moment.
So actually there's a sort of a protocol around the POTS diagnosis, you know, encouraging people to wear compression stockings or leggings and to really hydrate and to get more salts into your fluid. You know, if someone is beginning to go, maybe I've got POTS, should they be doing those simple things anyway to help themselves? Could it help and make a difference?
Absolutely.
Should we come to you or Mel? You want to take that one? I don't mind.
Yeah, absolutely. So there are a couple of core. So if you find that you're having some of those symptoms with long COVID or following COVID infection, these are absolutely crucial. And in actual fact, Boon and I have given some advice on webinars previously, giving that advice even during the acute COVID infection, because the key really, and it's very simple, some of these principles are very, very straightforward, is maintaining hydration, so being well hydrated, and drinking 2 to 3 liters a day of water, or non-caffeinated fluids. So it can be anything as long as it's not coffee or tea or alcohol. Making sure that your blood volume is replete, is full. In order to do that, because one of the reasons in these syndromes that we're seeing is that people are running on a dehydration or a lower blood plasma volume. So their heart is having to work much harder when they stand or when they do anything, when they do exercise. So making sure that you have a full plasma volume, so drinking 2 to 3 liters of fluid a day, not just when you're feeling bad, but every day. And adding salt to your diet. Now that goes against quite a lot of the advice that we doctors normally give. But the reason for that is, especially if you run a low blood pressure, the salt just helps your body hold on to the water that you're drinking. So it helps you maintain that state of hydration. It's particularly effective if you've got a low blood pressure. If you've been diagnosed with high blood pressure in the past, then don't follow that advice. The third thing is, as you were saying, compression garments, and we'll go into the physiology of that in a moment. But the reason for that is literally that when you stand, it's quite easy to understand. When you stand up, a lot of the blood in your body goes to your legs. And so your heart has to work much harder to get it around the body. And in POTS and in long COVID, that's one of the major problems. So wearing compression garments, and that's just pairs of tights or stockings that are specially designed to be compression, and they have to go up to your waist or ideally up to your belly button. So and what they do is they press those big blood vessels in those areas, and they encourage the blood back to the heart. So they stop the heart having to work so hard. And we can give some recommendations of where to get those types of compression stockings, but we would definitely recommend those 3 things before even starting. And a lot of people get better on that alone. The final thing, a bit like a compression stocking, is if you find that when you do stand up and you get a lot of symptoms, so you start to feel dizziness or palpitations, you can actually help the blood get back up to your heart yourself by performing some quite simple body maneuvers. And I'm sure, Susie, you've covered this in your yoga, but squeezing your buttocks and squeezing your thighs, so these huge muscles in your lower body, they literally squeeze blood back up to the heart. And if you do them at the onset of your symptoms or when you stand up, they can improve your blood pressure to the extent that your symptoms get better. So the maneuvers would be squeezing your buttocks, squeezing your thighs, crossing your legs. Sometimes just to augment it, you can cross your arms as well, and just squeeze your hands together like that, or squatting if things get really bad. And all of those help. It might be that,
As I'm sitting here, I've got my legs crossed and I was just squeezing my own buttocks and I felt the blood pressure come up. I felt more pressure in the arteries in my neck. It works. Yeah,
Yes.
That's great.
I mean, that is something that clearly works. And I think anyone who's watching this webinar after a lunch break feeling a bit drowsy or sleepy can test it, because when you squeeze, when you're getting that postprandial dip in concentration or lack of focus, you can often find that you suddenly wake up or you suddenly develop a level of alertness, because that is the blood which is being pooled in not only your lower limbs, but after lunch in your splanchnic circulation, which is the circulation of your gut. That is a blood coming back out from those centers of circulation back into the heart, and then making the fuller heart give you a better blood pressure, and as we'll describe shortly, down regulating your autonomic profile. So the other thing that I would add to what Mel has said is that some people, not all, could try the abdominal binder strategy as well. So it's almost like a Victorian corset that is quite thick. And the patients have told me about a particular way to get this, which is on Amazon. If you go to Everyday Medical and just look up umbilical hernia repair corset, it's like a thick band that you wear just from your solar plexus to your navel, and you wrap it around. You have Velcro to squeeze, and that actually compresses the splanchnic circulation, which is your gut circulation, which can feel a football field in terms of its capillary network. And those blood vessels can be squished back up into the heart. The final component is a postural. People who have low blood pressures tend to adopt this kind of postures when they sit. They tend to cross their legs, but they also tend to cross their hands. They tend to dig their hands into the solar plexus region, and they tend to lean forward, legs crossed. So whenever you spot a patient across the consulting room who's sitting like that, legs crossed, you can already guess that the patient's going to have a low blood pressure. If they start to rock their legs or fidget, then almost certainly they have learned to cope with that low blood pressure by agitating. So when you fidget and you move your leg, you're actually drawing blood or pushing blood back up into the heart and countering that low blood pressure state.
Gosh, that's fascinating. And I did not know that actually at all. So that's going to be really useful, I think. And there's a lot of people in the group who have got very low blood pressure. You know, we're talking down at that kind of 30 kind of BPM. It's extraordinary just to think that there's some little tiny maneuvers that you can do with your own body that will suddenly start to change what's happening inside. That's fantastic to know. And I'm sure there'll be some people out there right now playing with that as we talk.
Exactly.
Brilliant. Okay. We're doing well. That was sort of only one question. We have a lot. Let's move on and see if we can answer some of the specifics that are beginning to come on my list here. So, can a virus cause POTS? And there's two parts to this question, because somebody else wanted to sort of reference some studies that have been done where there is evidence autoantibodies are a cause of POTS. Do you guys have any thoughts on that?
Yeah, so we know Arthur Fedorowski quite well. He's at University of Lund, but I think about to move to Malmö, and he's done some of the major European work on autoantibodies in POTS. And what I would say is, so I'll say this very carefully, and it alludes to one of the points that you raised at the beginning about patients not really wanting to do anything until they had seen that specialist cardiologist or respiratory physician. I'll say it now. Don't let what you cannot do prevent you from doing what you can. I'll say that again. Don't let what you cannot do or understand prevent you from doing what you can, which simply means don't wait for that holy grail magic autoantibody drug, such as intravenous immunoglobulins or plasma exchange therapy, all of which are very expensive and under research investigations and not available clinically anyway. So there is the sense that there's a holy grail magic bullet that when you take it, boom, suddenly everything will disappear. Now we know that's not going to be the case. So this is subject to a lot of research and comes up a lot in the questioning. And when I say to this patient who's asking me about the autoantibody story, and I say, how much do you drink? And do you squeeze your buttocks? And they say, well, I drink a lot of coffee. I drink 1.5 liters, and I don't know what you're talking about when you ask me to squeeze. Tell me, what is the value? What is the bang for buck here? What is the ability to heal here? Is it to wait for the study to be published in 18 months' time, for the antibodies to develop in another 18 months or 3 years or 5 years, and then for that £50,000 per year drug to be sanctioned by whatever local government guidelines? In the UK, it's nice, to then give it to you on a selection, on a very carefully selected basis? No, you cannot wait that long. So don't let that stop you from doing what you already can do, and that's Extensible. So I'm not ignoring the question, but I'm saying that autoantibodies, sure, there is a concept that a virus provokes an antibody. That is how the innate immunity works, and the humoral immunity with the T cells producing antibodies. Some of those antibodies will cross-react to what's called the noradrenaline receptor antibodies. And just to get technical, the noradrenaline hormone is the sister of adrenaline. Adrenaline is your stress or flight or fright hormone. And when you have adrenaline, these adrenaline particles, think about that as a circle or a triangle, they lock into a receptor. So they lock into a receptor onto your smooth muscles of your stomach or of your lower limbs to squeeze those vessels and make the blood go back. So in some patients with POTS, they have selective denervation, or those antibodies attach, instead of adrenaline attaching to the receptor, the antibodies get to the receptor and they deactivate this receptor so that the adrenaline or noradrenaline no longer has an influence. I don't know whether I explained clearly enough. There's a receptor, there's adrenaline. Adrenaline sits on a receptor and causes an action, squeezing, pushing blood back up from your vessels. Now, if you have antibodies to the virus and those antibodies happen to look like adrenaline, those antibodies are not adrenaline, but they sit on the receptor and they block it so that the receptor can no longer lead to squeezing. Well, that is an autoimmune antibody-related phenomena that effectively denervates your lower limbs and maybe your splanchnic circulation, making you not able to cope with low blood pressure states because you can't respond in the usual way.
And I think the one thing to add, to reinforce in what Boon just said is that the idea of POTS being caused by a virus is a concept, and it's not. It's known that you can get some autoantibodies, but it's the link between viral illnesses and POTS is still debated, not very well understood, and so yes, certainly focusing on the practical things that we do know is probably more important.
Right. So actually right now, for the average layman, just focus on getting better and doing what you can do. Yeah,
exactly.
And, I think it is important to state that there are doctors in our group and, health professionals and researchers, and they're going to be curious. The brain is still kind of functioning. What's happening here? But great. Okay, wonderful. We're going to move on to a question about medication. And there's a lot of people in the group who have been described, and should I say, ivabradine? Have I said that right?
Yes, perfectly, Susie.
Okay.
So I'll take this one, Mel. The question I guess you're going to ask is ivabradine calming the nervous system as well as lowering the heart rate? And ivabradine is a drug, and there's a very unique drug. It's a drug that acts on two areas of the body. One, strangely, the retinal cells, causing flashes of meteors on the side of your mind, on the side of your vision. These are called, or the sensation of a light flashing by is one of the side effects of ivabradine. No harm done, you won't lose your vision. But the more important thing in relation to POTS and tachycardia is ivabradine acts selectively on your natural pacemaker and only on your natural pacemaker, which is called the sinoatrial node. And so when ivabradine is given, your natural pacemaker beats a bit more slowly. And so it's a useful way to combat the tachycardia. Now, does ivabradine lower adrenaline levels that drive the other symptoms? No, it does not. So just be very careful here. Ivabradine is an end organ effector. That means it acts on the pacemaker cell and prevents it from beating so fast. Do you understand? But it doesn't downregulate your adrenaline levels, which are causing the tachycardia in the first place.
So which is why it's actually fairly normal to still get increased heart rate despite being on this drug.
You will have a lowering of your heart rate, typically by 15 to 20 points. but it may not lower your symptom profile.
Right.
With one very curious exception, and I don't know whether we want really to go into this now, but it's to do with the feedback loop of autonomic dysfunction. And actually, I prepared a slide which kind of show, or a short series of slides, which actually show what's happening, which I think could have been helpful earlier on, but may still be helpful now. Do you want me to share this?
Yeah,
Shall I share this with your viewers?
There's quite a few people on ivabradine who would love to know just, what's happening with this drug.
Yeah, so for the moment, if you've been prescribed it and you feel better on it, continue to take it. How long for? Until all the other things we talk about start to set in motion an improvement and a momentum that gains, so that day by day you're getting back to normal. And at some stage, you can try to come off it, but probably take it for 3 to 6 months. If you are of a childbearing age and you could get pregnant, then be very, very cautious, because ivabradine is not safe in pregnancy. So if you were trying for a child, then I would caution you to come off the ivabradine and actually ask you to get yourself in a very good state, probably at the time that you're preparing to have a child, because you want to give yourself the optimal physical state. So if you're very severely impacted in long COVID, then having an early stage pregnancy is quite daunting and quite challenging physically on your body. So you might just want to delay for a short while until you put these strategies in place to make you feel better. So on that note, I'm just going to share my screen and probably use this opportunity to talk about a narrative of long COVID. And right here, I'm just going to start by sharing this screen, which is called stopfainting.com. It's a charitable website that is free for use for everyone, and it's created by kind of Mel and myself and the team at Imperial, including Andreas and Trish, who are the two syncope nurses. Andreas has now since left to Germany, but if we go to the "Why Do I Faint" section, I just want to talk you through a narrative here. And you can all go back here and you can watch a video at the bottom, which is a YouTube illustration about how this works. But very, very briefly, I'm just going to click on this bottom left red corner, see how it happens. So when you are looking at this, I want you to imagine that you have a heart that's pumping, a brain that's full of red stuff, the circulation that is in red as well. All this red stuff is blood. And when you first stand up from a seated, seated position, your blood pressure is in a green zone or normal. When you stand up, gravity starts to pull blood down into the lower limbs. And I'm going to exaggerate this again. And so gravity starts to pull blood into the collecting organs in the lower veins, and your blood pressure has now dropped from green to amber. So for example, in a reading that your clients might have, they might go from 110 to 90, for example. I'm going to bring in a second screen now, and just to show you that when we talk through this narrative, what we can see is that here, I don't know whether you can see that, the heart is full of blood at rest, and when you continue to stand, the blood starts to drain into the lower limbs. And when it does so, the heart starts to empty of blood with continued standing. And the blood pressure you can see here has started to fall here. So this blood pressure fall is because the heart has emptied of blood. And so when it does that, I've talked about the blood pressure falling, and this heart that empties of blood, and this is the key component of autonomic dysfunction here, it sends a signal, because every stroke volume of this heart, which is struggling because it's empty. So this autonomic dysfunction or POTS is also known as the empty heart or the small heart syndrome or the Grinch syndrome, because the Christmas Grinch had a very small heart. And if your heart is empty and your stroke volume is reduced, then the only way your brain knows how to respond to this emptiness is through a reflex mechanism that's typically mediated by two receptors in the neck called the baroreceptors, which are here. And this signal to the brain from the empty baro reflex here with an empty stroke volume, it activates what's called a fight or flight response. So this is a helpful thing. if we're very dehydrated, we don't have POTS, we don't have long COVID, and I'm quite dehydrated, I haven't drunk enough this morning, and I stood up very quickly, my blood pressure would fall slightly, my stroke volume would fall slightly, and that is usefully going to activate adrenaline or fight or flight response here. And this adrenaline maintains the cardiac output to maintain the heart filling. How does it do that? It acts on the heart directly. How? By increasing its heart rate. It also increases the contractility. That means the strength of contraction is more enhanced. And in doing so, it counters for the reduction in stroke volume we had, because we know that the cardiac output is ultimately stroke volume times heart rate. So if stroke volume is reducing and heart rate is increasing, guess what? Your cardiac output is maintained. Your blood still can circulate around the whole body and the brain is perfused. You don't pass out. So the sense of an increased heart rate gives you palpitations. And that is what the palpitations in patients with POTS feel. But also there's a sister hormone of adrenaline, and that's called noradrenaline. Noradrenaline, we talked about previously, is the principal vasoconstrictor. That means it causes your vessels to constrict. And what happens when you constrict is you push your blood back up. So you can try that now without noradrenaline by squeezing your glutes, squeezing your quads, squeezing your calves, and that will do a very similar thing and push the blood back up to the heart. And as a result, the heart fills up here. I'm trying to draw a filled heart, and it normalizes your blood pressure. And then you dial down the adrenaline, correct? All this happens in just 15 to 20 seconds normally. So if I stood up now, I would, and you stood up now, Susie, you would get a heart rate rise. You can test it later if you have an app or something to measure your heart rate of between 8 and 15 beats a minute. But within 15 seconds or 30 seconds, it will come back down to your baseline and maybe sit at 3 to 5 beats per minute higher than what it was when you were sitting. And this is the impact of adrenaline. And so it's helpful to have a little surge of adrenaline to maintain the cardiac output. And what happens now is that in long COVID, and this is the key slide, in long COVID, you activate this adrenaline response, but you are unable to improve your blood pressure or heart filling through a variety of mechanisms. And if your body becomes less responsive to the adrenaline, in particular with the fluid coming back to the heart, guess what? You activate more and more of this profile, and you go around in a continuous circuit of activation. So I just draw it for you now. You activate the fight or flight. You cannot push blood up. So your heart remains empty, so you activate more. So you get more adrenaline. You try and activate, you can't, and you get more adrenaline. And therefore you get continuously tachycardic. So your anti-gravity shield fails. And when it fails, you get more and more of this activation, and you run into a trouble point here. And I'm going to let Mel take this for the moment. Mel, do you want to talk about this slide?
Yeah, so this is a lovely slide that basically shows all the different organs, systems in the body, and it shows their response and how that they the effects of this persistently elevated excess levels of noradrenaline in the body. So if we start at the top, you've got your brain, so persistently high and excessive levels of noradrenaline circulating. You get the brain fog, which we've talked about. You can get irritable, a sense of anxiety, of always being on edge, of not being able to focus. Some people report memory problems. We've talked about the heart, of the sense that your heart literally beating faster all the time because of this extra sense of adrenaline. So everything that comes with, which is chest pains, shortness of breath. There are interesting effects on the intestines. So having excess levels of noradrenaline around can actually, it's just causing that extra level of stress. You can get cramps, you're more likely to get diarrhea. It can affect the amount of nutrition that you're absorbing. As we touched on earlier, you can have effects in your reproductive system. So some people might report changes in their periods or their sex drive because of this persistent effect of adrenaline and stress on your hormones. Your muscles can become painful and swollen. And then, interestingly, in terms of the immune system, you can, if your body is consistently under the kind of strain of excess noradrenaline and excess stress, is going to be less effective at fighting infections or responding to a blip later on. And I know one of the questions that people do ask is, you know, what will happen if I get an infection in long COVID? And sometimes the effect of it might be worse for this whole variety of reasons. And then, a lot of people might report symptoms with stomach ache and reflux and difficulty, intolerance to certain foods, changes in their appetite, the inability to eat certain foods after it, and then skin, which is often the window into the body. So, you know, whatever's happening inside the body will be shown on the skin, whether it's spots, acne, swellings, rashes. So it is really a whole body effect. And what this diagram doesn't show, which is often the symptom that people complain of the most, which is this profound and debilitating fatigue. And you might think, well, why does noradrenaline supposed to be sort of give you energy and get you going? But if it's persistently driving in this vicious sort of fight or flight response, if you're feeling constantly on edge and you're ready to fight, so the whole purpose of the fight or flight system is to be able to run away from a lion, but this is a chronic fight or flight that's unable to dial down or turn down. It's exhausting for the body. It's working 3, 4, 5 times as hard as it should be. So to get that debilitating fatigue, and a lot of people say, you know, again, something that's not shown on the slide is problems with sleep. So, you know, if your noradrenaline is circulating through your body and you're in this state of trying to run away from a lion, the fight or flight response, how are you going to be able to go to sleep at night? And a lot of people will report persistent palpitations. You know, they're lying in bed and their heart is just pounding. And so it really does affect every part of the body. But fatigue and sleep, once you have them, it becomes very difficult to then even deal with or counter some of the other symptoms that you're getting, because these are key for your general functioning.
Agreed, totally. I'm remembering my sort of worst point around the end of this time last year, basically. The adrenaline levels in my body were so high, my body would not let me sleep for more than an hour. And, you know, even on double dose of sleeping tablets that my doctor experimented with, there was no way that was cutting through the adrenaline. And that was sort of the demise of my physical well-being. My
Absolutely.
body just couldn't recover. And that, I think, is a really common feature for so many people, that adrenaline surge that just, you can't do anything about it. It feels like it's overwhelming.
Yeah.
So I would just add that the impact of having a heightened adrenaline can be shown here in this diagram. So this adrenaline effect will lead to vigilance or hypervigilance. And it's the very same hypervigilance that makes somebody with long COVID very wired. And this wired state prevents a very effective sleep pattern, because in the state of play, in a normal body's 24-hour state, we have what's called diurnal variation. And this is mainly mediated by variations in the autonomic nervous system. So on the one hand, we call it the fight or flight response, which mediates our activity. It's very yang, a very positive sun-like energy. And then on the other side, I think of it akin to the yin, or the resting or digesting or rejuvenating side of things. And that's the vagus. For those of you who don't know, this is the vagus, also known as the vagal response. And this is the direct contrast, or the yin to the yang of the sympathetic nervous system. The vagus is the calming side of things. So this vagus is what is lacking, or the expression of the parasympathetic nervous system is often what is lacking. And we have to think about strategies to enhance vagus and downregulate sympathetic nervous system.
So I have a question, because obviously everything that we're talking about here, if this is left to run for long enough, is that basically what dysautonomia is? Is it this? If this is running in the body for long enough, it becomes dysautonomia.
I'm going to pause for a second, guys. Mel, do you want to take that question? I can listen, but I'm going to change rooms because the kids are having breakfast. Thanks.
That's a great question. Yes, I mean, dysautonomia literally just means dys is abnormal and autonomia is the autonomic nervous system. So the term is an impaired autonomic nervous system. So actually what Boon has just described, this whole concept of the persistent fight or flight response, is, we would call it dysautonomia. So it's your autonomic nervous system not responding as it should. So yeah, exactly. And just one final thing to say, that actually from these diagrams and animations that Boon has shown, it can also explain why drinking fluid, salt, compression stockings, and those exercises can help, because all it does is it stops that blood from pooling in the lower parts of the body and gets it back to the heart, so you don't get that empty heart syndrome or reduced heart filling that is the sort of trigger for all of these symptoms.
Although a lot of people will be experiencing these symptoms from bed, they're not even getting up. And, you know, I
Yes.
definitely experienced that myself. And I didn't get out of bed for days and days, other than, you know, a quick bathroom check. But, you know, the adrenaline levels were firing off all of these symptoms. And I was mostly lying in bed. And I just felt like I wasn't even lying down enough. There wasn't a bed that was comfortable enough to let me feel like I could rest, because the adrenaline levels were so high. So is that the same thing, even if it's not about a position change?
Yeah, so I would say that's a fairly common finding when you're very severely affected, especially in the early stage, in week whatever 2 or 3 following your initial long COVID insult until maybe week 8. But there are a cohort of patients who get better, and then they get a lot worse at some variable interval, maybe 3 months after they recovered. And there's almost a dip with the initial acute long COVID, a recovery, and then a stronger dip to give you the symptoms of long COVID. It's a common finding. And the stronger dips can come at various times. You can have and here this is anecdotal now, Mel, you can have a dip even after you have a secondary illness. So for example, if you had a UTI or you had a very stressful time or a bereavement, 2, 3, 6 months after your initial long COVID, you can get a dip. I've seen a few patients report to me that after they had a vaccine, they also had a dip. So we've got top tips for receiving a vaccine as well. If you've had long COVID before, if you've had COVID before and you're receiving a vaccine, you need to get yourself primed before you receive the second vaccine so that you minimize the chance of the next long COVID response. Because after all, the vaccine generates autoantibodies, right? That's what we want the vaccine to do, to fight the COVID infection the next time around. So the specific answer to the question about lying down is probably, and here again, it's a guess, but a guesstimate which is based on some research, mainly by NASA, which is the Aeronautical Space Agency in the States, because the physiologists at NASA do a lot of anti-gravity physiological work, and when astronauts come back from space, they have autonomic dysfunction. And actually, if you look at just YouTube astronaut giving press conference interview fainting, a lot of them describe that they feel drunk, they feel they can't steady themselves, they have brain fog, fatigue. And what do? They need to retrain against gravity. So in a very similar way, people with long COVID who have been flawed for 2-3 weeks and have not really got out of bed and are not drinking that much water, very much like the NASA astronaut, has reduced their plasma volume. The reason these astronauts feel like they have POTS is because their plasma volume is reduced. Let's suppose this red stuff that you see in my diagram, the circulating amount of blood, is starting off at 5 liters. Now, at 5 liters circulating, if you've been flawed by long COVID for 2 weeks and lay in bed, you might then have 4.6 liters or 4.8 liters because you've lost 200 mils from physical deconditioning. So one of the things is not only do your muscles become atrophied or weak, you also physically lose plasma volume. How do you lose it? You lose it through a very interesting system, which is fairly complex, but I'll summarize it. It's called the Renin, Angiotensin, Aldosterone system. And that's a system that maintains your plasma volume. It's a very intricate neurohumoral response, which means your brain, your heart, your vessels interact with your kidneys to tell your kidneys how much urine it should be producing and how much salt it should be reabsorbing. So guess what? People who have spinal cord injuries and are lying flat for a long time, guess what? The circulating volume reduces because they are effectively an astronaut, not fighting gravity. People who are upright, doing more and more exercise, reconditioning against gravity, will gradually express more of the renin, more of the angiotensin, more of the aldosterone. And these are all hormonal systems within the body that help to retain salt. So it is your natural salt replenishment tablet to be standing upright. And if you don't, and if you lay in bed for longer and longer periods every day, that's when you lose more capacity to do even more. So it's a vicious cycle, and you should not be resting in bed or a sofa all day. At least spend some of your day upright. And if the most gentle exercise is just standing against a wall for 10 minutes or 5 minutes, twice or 3 times a day, try and do that because you need to learn to fight gravity again to get your plasma volume up.
That's fascinating because, of course, you know, for most of us, the instinct when we were in that kind of acute phase is, I can't possibly get up. Are you crazy? You know, and so it's amazing to hear that actually that's one of the ways out. That's part of the toolkit.
And therefore your toolkit where you're providing patients with resistance-based exercises whilst lying, especially in core and lower limbs, as you'll see that those are the key components where your anti-gravity shield lives, are key components. So the recumbent exercises with the lower limbs is a transition step before the more upright exercises. But please don't try, if you're lying in bed all day, don't say, oh, I need to exercise, let me go for a 20-minute jog. Of course that will floor you. So you need to start
I think we've
slow.
all past that point now. I think we've
Sure.
all learned that lesson a few times.
Sure, there are some patients still who feel they're getting better, and then they feel, okay, today I'm going to go for a run. Now that would be too much. So you need to pace yourself, and that's why these pacing strategies that you teach in your class are so important, so that you build things up gradually. And no doubt the recovery will feel very much like a 1 step, 2 steps forward, 1 step back kind of recovery. But you need to recognize that if you're doing a 2 steps forward, 3 steps back, because you're being floored every time you try and push yourself too hard, that is too much. Dial it down a notch.
And I think that's that really goes some way to help people, hopefully, feel encouraged that exercise is part of the way out. And I think people are really afraid of exercise because they're afraid of post-exertional malaise. But actually, it's about finding the baseline. And I think for some people, comprehending quite how low that baseline is quite a big thing to get their heads around early on. Because just the idea of lifting one arm in the air and putting it down again, you know, you wouldn't even call that exercise a year ago, but that is now the right kind of exercise to get you back in this kind of slow, gently rehabilitation program that we're trying to do. So that takes me actually to the question that we have here, which is what can we do to help our bodies go back to a state of normality? We're kind of answering it here, but is there anything else to add?
Mel, do you just want to re-emphasize the physical maneuvers, and I'll try and draw on this picture everything that you say.
So the
top
key,
tips.
The key things to the sort of take home messages are: 1, ensure that you're hydrated. So drinking 3 to 4 liters a day, if provided you're not on a fluid restriction. Avoid caffeinated drinks if you can. So anything that's going to make you pee more, that's things like coffee, tea. A lot of people feel that with long COVID or autonomic dysfunction, actually naturally stay away from alcohol, but that's another thing because it can make things worse.
Mel, can I just ask a quick question about coffee?
Yeah.
Decaffeinated coffee, is that also one to be avoided? Because I think a lot of people experiment with that.
It still has some effects of making you pee more, but it's a reasonable compromise. You don't want to remove all kind of joy from your life. So
I've become less evangelical about caffeine avoidance, Mel, over time, because if patients need a kick and actually they feel it helpful, then it's okay. But oftentimes patients will tell me, when I have a double espresso, I get palpitations. And then I say to them, you know what your body's trying to tell you, stop. But if they feel good on taking 1 or 2 cups of decaf tea or coffee, I really don't mind. So I don't think there's any strict rules here. I think everybody's body is going through a different phase of autonomic recovery. So we don't need to be so precise, but the hydration, we will suggest pushing, obviously.
In order to hold on to that water that you're drinking, add salt to your diet. So if you run a low blood pressure, we normally say 2 to 3 teaspoonfuls a day. So that's adding to your diets. Obviously, if you've been diagnosed with high blood pressure in the past, then that's not, then you shouldn't do that.
So I just want to give your clients some tips, which is the blood pressure measurement should always be done seated, legs not crossed, resting for 3 to 5 minutes, slow breathing exercises, upper arm cuff. The brand I like is something like Omron, and M1 or M2 can be bought for 30 to 40 pounds on Amazon. And Omron, O-M-R-O-N, upper arm cuff, and the cuff needs to be fitted to your size. That's the most important thing, and needs to be upper arm. The wrist cuffs are not as validated. So this is one thing that you should understand, and specifically the values of a normal blood pressure are anything under 135/85. Low normal, I would suggest, is anything below 110/70. And so if your blood pressures are hovering in and around the 110 value, then you know you've got a low normal blood pressure and plenty of room to play to give yourself more salt without causing any serious damage.
Okay, that's really worth knowing. Thank you. I'm aware we're going to start to run out of time for this part of our Q&A, and I'm aware that we have only really covered about a third of the questions. So I'm just having a little look down. Can we go to, I'm hoping is that there's a quick fire yes or no response section that we can cover off before we let go of you guys today. But maybe we can make an arrangement to come back and talk about HRV, that's heart rate variability monitoring, and the bigger picture of recovery, understanding that a bit more, and various other amazing questions that we have been offered for discussion. But if I come to my yes or no, and I think actually it may well have been answered already, but can getting a bacterial infection on top of long COVID make tachycardia symptoms worse?
So one word?
Yeah. Yes. There we go. Exactly. Perfect. Thank you. Maybe we can answer this with a yes or no. Does scarring on the heart caused by post-COVID myocarditis heal over time?
Maybe. I'm sorry, but the long answer is the scar in the heart tends not to heal, but the heart itself will heal over the scar and compensate for the scar. So you don't need to be worried that you'll have a impaired cardiac function for the rest of your life, but there will be remnants of the scar that you can see for many years afterwards. Can you hear me?
Yeah. Oh, I can now. Sorry, I lost you for a moment. You're back. I heard your answer though.
Okay, you did. Okay.
Yeah. Can people fully recover from POTS?
Yes.
Hooray.
In one answer.
Is it possible for children and or teenagers to have POTS?
Yes.
Right. And the protocol is exactly the same for them too.
Correct.
Yeah, great. I'm looking at my watch. Do you think we have time for one more?
Yeah, we have 10 minutes. Well, 10 minutes. I have 10 minutes.
Okay, great.
It's 9:05, right? Yeah.
Yeah. So let me come in with this one because I think it's more of a discussion. Do you know any more about why long COVID may develop in some people and not in others?
Phenomenally fascinating question, and one that I've had several discussions with Mel about. And you probably also have your own opinion, Susie, which is going to be very helpful in aiding this discussion. But there is a particular group of patients. One, it's a high propensity for females. Number two, the age range tends to be lower from a teenage female to, say, a 45-year-old female. That's the kind of age group. We seldom see older people with long COVID symptoms. We seldom see them. Thirdly, they tend to have they typically have a pretty good state of health pre-COVID. And when I say pretty good, it's so good that they are exercising regularly, and actually their blood pressure at baseline has always been perfect, when in actual fact, it could have been relatively low, as sometimes athletes have low blood pressures. And so this concept of the fit and healthy female patient in the younger or middle age who had a low normal resting blood pressure, and then you add in one additional ingredient. And this ingredient, I don't mean this to be gospel or backed by evidence, but it's just an observation in that people are very almost type A personality, which means they're very, very much go-getters. And the way I think about this is that for you to be a go-getter, for you to be type A, for you to want to achieve good grades at school, good work profile, good salary, good everything in life, your brain needs to be conditioned to respond in a very particular way to the threats of the external environment around you. Now, that threat could be your colleague in school getting better grades than you not getting to your university, but your brain perceives that in a slightly different way to somebody else who's more chill man. So if you're chill and you're not that kind of person who responds in that way and have not been all your life, it's, in my opinion, perhaps less likely that you get long COVID or symptoms of dysautonomia. And that's a very, very broad generalization, but these are some of the traits that I've observed over the years that tell me about some of the particular characteristics. And it could just be the way the brain and the autonomic nervous system is wired to respond to the external stimuli around you and your precondition on management of stress. And you'll know that actually in your clients as well, and I know that some of my patients handle bad news or stressful news very well, and some don't. Some react by going on the internet and they spend a whole week on the internet and come back to us with 100 questions. Some say, look, doc, you just tell me what you want me to do, I'll do it. And they get better the next time you see them because they're just doing everything you tell them to do. And some will say, why are you asking me to drink 3 liters? Why not 3.25? What's the evidence? That tells you that that patient is already of that particular make, that very patient who's asking that detailed question about the phenotype of the autoantibody profile of the long COVID, right? Because that is the type of stress response or the conditioning of the brain to ask that question tells you about that person's response. I appreciate this is not, this again is very maybe provocative and controversial, and it's by no means a judgment to any of your people who are watching this, no means judgment. I'm just declaring an observation that I've made over time on these kind of traits. And I'm not sure that I've said it well enough, Mel. Mel, perhaps you have a more, better way of saying what I've just said.
No, I think that's, and I think the other thing is some people, we don't know why they get it. There's been very little research work into long COVID to look at this. And then there's just the other kind of very practical risk factor, which is some people, and these are the people that probably benefit from you, Susie, are those who have hyper extensible joints. So some people might find that there is a certain kind of condition that can make your skin and your joints a bit more bendy, and that's great for yoga and it's great for them coming, but it means that they're more likely to develop that pooling of blood in their legs. So when they stand up or just at any time, they lose more blood into their legs and they're more likely to get these syndromes. And that can be a predisposing factor. And you can go through life not necessarily knowing that you've got it not being a problem. But when you're hit with this extra stress, then it can become apparent.
And just to be clear, that's also known as hypermobility. And in the complete form of this, there's something called the Ehlers-Danlos syndrome, which gives patients susceptibility to developing these pooling syndromes and autonomic dysfunction.
I think it's fascinating that you're talking there about people's natural stress responses and the way that their brains work. I think for me, when COVID when COVID hit, I knew that if COVID met me out of my family, it would be me that did something more interesting with it. You know, I have a history of using illness as a means of my body trying to de-stress. And so there was a sort of almost a pattern there of actually, we know that the only way that you're going to stop and slow down is if we give you a chest infection or if we give you tonsillitis. And actually that's been, you know, just a story in my life. And I think many people, because we've asked this question into the group, you know, who here as a child had multiple rounds of antibiotics? You know, oh yes, look, there's a lot of us here. I think it is important to also say, on the other hand, that there are obviously anecdotally people who are saying, no, that wasn't me. I was really happy. I retired. I'm feeling great. And it got me. So it's a very complex thing, but I think really beginning to understand that mind-body connection is fundamental for people to begin to think about how they can work here to get their bodies back into a healthier place. And it is a lot about, what are you thinking? How are you approaching your recovery? Are you anxious and worried about it daily, or are you going, actually, the thing that I need to do is find center, calm myself down, ground myself, reassure myself, you know, I am my body. Yes. My body is me. And so if I was going to look after me, if I was a child, if I was my own child, what could I do to help heal me? And I think that's been something that I've really embraced in my own recovery journey.
I would subscribe to your class immediately, Susie. You have a phenomenal way of communicating that narrative. And actually, this is something that we as medics, A, don't understand, B, generally are too arrogant to want to understand because it's not sciencey. It's very the opposite of science. There's mind, body, and the third component that you have in your website, as I can see, is mind, body, soul. We haven't even touched that aspect yet, but it's something that I would love to explore with you on a future webinar, because this is also my fundamental opinion. I completely agree with you. And of everything, this is likely to be the most important factor in driving success. So physical, yes. Do everything it says on a tin, yes. But changing mindset and changing expectation, behavior, guided and anchored by education, and then having empowerment, i.e., you know what you do is going to make you feel better, and then executing those things are going to be fundamentally how we improve from this long COVID component. And you are going to play a major part of it as you progress and develop this narrative of how to cope with the mindset shift and the expectation shift. And you know, it's wonderful. We could talk about that for hours. Yes, Mel?
Yes, exactly. And then the final thing is doing that as part of a community. So having that social connection, which obviously you offer, and there is that, you know, there is scientific evidence to show that that can promote healing as well. So that's very important.
Oh, absolutely. So we did. We can have this be the last comment, but we did 3 courses with the Oxford University Mindfulness Center. And actually, in the focus group, the thing that came out as the most significant healing element of it was the fact that they were with 25 other people who understood and really got it and shared the story. And it felt so empowering. That feeling then resets the system. Yeah. You know, you kind of
so we didn't cover this, but I feel fundamentally that the influence into the autonomic nervous system in 2 ways. Yeah. 3 ways. One, the physical maneuvers. So we deal with the lack of blood pressure, lack of blood volume. Second way, just very briefly, is this is conscious thought. When I'm moving my finger and I'm speaking, I'm thinking about what I'm going to say, and then I say it, and I move my finger, conscious or somatic nervous system. How do I say heart rate reduce? How do I say breath rate reduce? How do I say fatigue go away? I don't. But guess what? I can make you have a high heart rate. How? I can make you angry. I can say insulting things. I can provoke anxiety, and that increases heart rate. So guess what? The window into your heart rate control is emotions and feelings.
Yeah.
And so the opposite of that must also be true. So if anxiety can provoke an increase in heart rate, guess what compassion, gratitude, love, and expression of all these positive emotions can do to your heart rate and autonomic nervous system? It really does downregulate that. And the other twin component that is practiced a lot in yoga is, of course, the breath. And you just have to take an experiment here. And I guess, take your pulse, breathe in for 6 seconds, hold it, breathe out for 6 seconds, hold it. And you'll see yourself, or all your clients watching this will notice that your heart rate increases at peak inspiration and decreases at peak expiration. And this is your own heart rate control. So you can control your heart rate. You can control your emotions. You can control your autonomic nervous system, and you can heal yourself. So that is the key thing that we want to get across.
Right. It's true. And it's so exciting to hear you say that, especially because you both are from a medical background. It's so exciting because it allows us to believe in the work that we're doing this end, instead of saying to people, you know what, just coming into the classes and feeling a part of something, having something in your diary, have a moment where you're laughing with us, have a moment where you feel like yourself again, because there's some work that we do where we get people to just remember a time that they felt good. Where were you? What was happening? What can you smell? And part of the meditation, is just to help remind people's brains that they can still feel good again. And that support and that sense of togetherness on a journey is so powerful. So it's great to hear you also acknowledge that it's not mumbo jumbo. It's true.
No, it's key. Yeah, it's the fundamental.
Fantastic. Listen, guys, we're going to pause it here for today because I sense that the three of us could talk for a very long time about this. But I promise whoever's watching this, if we haven't picked up your question, I'm hoping to get these two back into the room with me again, and we're going to pick up where we've left off. But for now, Boon and Melanie, thank you so much for your wisdom and your thoughts and your words. Absolutely amazing. And I'm sure many people listening will be delighted to hear you've been sharing with us today.
Thank you so much for inviting us. It's been lovely to talk.
Thank you, Susie.
You're welcome. Thank you.